And I repeat, that time now the thyroid functions were still within normal ranges.
Okay, so for me, it appears like initially maybe this patient had a genuine case of hyperthyroidism that resolved with treatment. I'm not so sure for how long that is going to be sustained, but now that you're saying that for this recent presentation, the mass is nodular and has been
Yes.
rapidly growing, then it's
Yes.
possible that it could actually be a case of thyroid cancer, of which a biopsy would really help us come up with a diagnosis. It's a good thing that you're
Yes.
planning to take the patient in for theater because that is likely
Yes.
to be more definitive than an FNA.
Yes.
So should they confirm the presence of malignancy depending on the type? The options that are available would be radiotherapy topmost, followed by either the possibility of, you know, chemo or surgery to remove any tumor that is still remaining. But again, that will depend on whether there are metastases elsewhere or not. Now, I haven't seen the report for the CT scan very well. Did they report any metastases?
Yes. They reported mets to the lung. The CT scan that was done showed a nodule on the right apical lung nodule. But the chest X-ray that was done before the CT was also suggestive, had these opacities bilaterally.
Okay, so it would be important to just make sure that is not pneumonia. Maybe eventually we want to repeat some more imaging investigations. But if
Yes.
indeed metastasis, then our plan is going to be geared towards preventing the local symptoms that may arise as a result of having a large mediastinal mass and a neck mass.
Okay. So in her case post-op, if it's confirmed to be malignancy, do we consider the radio or?
So usually radioactive iodine ablation therapy is more or less
Yes.
the first line for thyroid cancers. But it's
Yes.
important for us to know that if they cannot access that, there may be the possibility of trying external beam radiation therapy as well. So,
Yes.
and it's important for us to not assume it's a malignancy until it is confirmed.
Until yes.
Should it turn out, then that would be the right way to go. I understand that in Nairobi they are able to do radioactive iodine ablation therapy. So we should
Oh, okay.
just make sure we work the patient up quite fast so that we don't miss out on a chance of long-term control of his symptoms, her symptoms.
Okay.
A question, please. I see the patient had underwent thyroidectomy in 2016. Is it the same specimen which showed the signs of follicular carcinoma, or is this a FNA?
No, the initial FNA and histology post-op in 2016 were both reported as benign lesion.
So it is the FNA which is showing the features of follicular carcinoma.
No, this time round, the FNA was also reported adenomatoid change. But now, on further review, because of the clinical presentation, history and exam, we thought might be more of a malignancy than a benign lesion. Because remember, FNA doesn't really pick out the follicular carcinoma.
Okay.
Okay, that's fine. Any other questions on that case? Otherwise, we'll move to the next.
So I think some people can go to your next case. Let's finish up with your cases so that we can do our case on this other side.
Good morning. Can you start?
Yes, you can start. We can hear you clearly.
Okay, I'm Adagi. I'll be presenting the next case. So, EAA 29-year-old female para 2 plus 0, who is a housewife, is a newly diagnosed RVD patient since 5th of this month on heart and currently admitted at our gynecological ward, presented with complaints of low abdominal pain and swelling for 3 weeks and lower limb pain for 2 months. Also reported associated history of weight loss, night sweat, with on and off fever and nose bleeding. On examination, was sick looking, in pain and not in distress. She has oral thrush and no peripheral adenopathy, no lower limb edema. So her abdomen was distended and has a pelvic mass about 22 weeks with a mass noted on the left hypochondrial region with a positive fluid 3 and no organomegaly. She also has a right inguinal mass about 10 by 5 fixed and non-tender. Systemic exam was unremarkable. So she had a CT scan done that showed bilateral lower abdominal mixed attenuated masses, one 17 by 11 centimeters and the other 11 by 11 centimeters, some ascites and right inguinal lymphadenopathy. So we had an impression of bilateral large ovarian tumors with inguinal mets. So that's the report of the CT that showed the features suggestive of bilateral ovarian tumors with associated small volume ascites and right inguinal adenopathy and pararectal soft tissue density adenopathy. So they recommended for us tumor markers, and the chest X-ray done basically didn't show any features of mets. So she had an inguinal biopsy done and histopathology macroscopically. Lymph node showed fragmented fatty tissue together 20 by 10 by 5 centimeters. Microscopy sections show fatty tissue infiltrated by diffuse large round cell tumor. The cells mainly nucleus with rim of cytoplasm. So their comments were features are consistent with the large cell lymphoma and recommended an IHC. Diagnosis of malignant diffuse cell tumor was made. So that's the histopathology report. So plan was to prepare the patient for CHOP as we await for IHC. We do beta HCG, LDH, CA125, CEA, CBCs, and UECs, and start her on morphine, 10 milligrams QID with lactulose. So when we reviewed the patient with results, her CBCs, she had a bit of neutrophilia with HB of 12.2 and microcytic hypochromic with a normal platelets. U&D's urea was 8.4 as you can see, and creatinine of 90. So LDH done was markedly high at 3,946 with a beta HCG level of 3. So in summary, I was presenting an EA 29-year-old female para 2 plus 0, newly diagnosed RVD on heart with a diffuse large cell tumor with a suspected ovarian mass at ECOG status 2. So the point of discussion is any role of surgery to reduce the tumor bulk in ovarian tumor. Is choice of chemo correct as we await for IHC? the long-term prognosis, and any other input in terms of workup and follow-up. Thank you.
Can you hear me?
Yes.
My name is Dr. Kilat. I want to find out what are you treating here? Are you treating lymphoma? Are you treating ovarian tumor?
For now, we started the patient on CHOP as with the histopathology results, but we are still waiting IHC. So we brought it on the table to discuss if we proceed with CHOP or we wait for IHC results, and we haven't started treatment for the ovarian yet.
Is there about taken from the ovarian mass?
Sorry?
Is there about taken from the ovarian mass?
We haven't done a biopsy yet. We only took a inguinal biopsy and gave us the histopathology results.
Because I think maybe you need to have a what are you treating? Are you treating lymphoma? Lymphoma or another malignancy, because treatment will be different. And if it is lymphoma, then there's no role of surgery, because the lymphomas will want to give chemotherapy. So there's no role of surgery. So I think it's important that is also sure. If the IC will take longer, maybe you can take another biopsy from the ovarian mass, so that you are sure.
We can't hear you.
I'm saying
Yes.
you have to be clear about the diagnosis, that you're treating lymphoma, and if it is lymphoma, then there's no role of surgery.
Okay.
Dr. Kilach. So, myself, I'm also wondering if you have a diagnosis for this patient. Of course, the LDH is very high, which means maybe you have a high turnover of the cells. It's possible it could be ovarian lymphoma. It's not unheard of. Of course, you can have large B-cell ovarian lymphoma, buckets. So, IHC will really help you confirm the diagnosis. Now, as you're waiting for the confirmation, you may want to start on other form of treatment that would help prevent maybe kidney injury. So I hope the patient is on allopurinol at least. She clearly has a very high, and the uric acid is also high.
Okay, yeah, I'm sorry I didn't mention it there, but it was also on the plan to start the patient on allopurinol as well. Thank you.
And of course, good hydration.
Yeah.
So it's also important to eliminate other possible tumors of the ovary, like the carcinoma. So I also have the PA25 and any other tumor marker that you can think of that points towards an ovarian malignancy. But at the end of the day, immunogs will really help you come up with a diagnosis. And as Dr. Kilach has said, regardless of how bulky a lymphoma or tumor is, you don't need to operate it. If you start on treatment, they really shrink quite fast. Anyone wants to comment on long-term prognosis, reproductive? Of course, the patient is getting chemotherapy, and generally speaking, patients who are subjected to chemo, some of them end up with premature ovarian failure, maybe in their 30s or early 40s. So that is something to consider. I'm not so sure if there is any other implication unless the lymphoma has destroyed the ovary through local invasion. Any other comments?
Maybe you're still deciding if POP can be okay right now. Maybe IT will take longer and you want to treat the patient. So one thing, maybe you can have that CA 125 done, and if it's normal, then it will have with a high possibility of ovarian malignancy. That is only epithelial of the CA 125. And if the patient is quite sick and the risk of waiting might be bad for the patient, so you can go ahead with good clinical suspicion to start treatment with CHOP. And if actually they respond to it, then your suspicion for lymphoma is quite high. But you still need to make that conclusive diagnosis with the IHC.
Okay.
Any other input from the audience?
I just want to ask, like, how long do you think will take for the patient to do the IHC?
At times there's a challenge with the finances, but they told us that probably this week we can get the IHC results.
Do you think the patient can afford?
Because they managed to buy the CHOP, so we are hoping, yes, they'll be able to afford that.
Okay.
But I'll consult them on that because she doesn't have NHIF though.
So we have a lymphoma program. We can try consult with them, see if they can pay for the patient. So please get in touch with us after this case.
Okay.
Next case, if there are no other issues coming up from this.
Thank you.
Kisomo, do you have another case?
No, we don't have another case.
I think we can get.
So maybe before we get started on the next case, thank you so much, Dr. Kibet, for joining us this morning. We just came in after we've discussed an interesting case of a 23-year-old female patient who's on heart, who presented with abdominal distension. They did investigations, a CT scan, and they saw two masses in the pelvis, I think on both ovaries, measuring on average 11 by 7 centimeters on either side. Of note is that the patient also had an inguinal mass, and a biopsy was done, which showed features suggestive of lymphoma, likely large cell lymphoma. The LDH was about 3,900, I think, with a normal, is it alpha fetoprotein? Yes, normal alpha fetoprotein of 3. So the question was what this is likely to be. Of course, they need to do immunos. A biopsy was that was done was on the node, or rather the mass on the. Yes. Let me give you a microphone so that they can hear. Okay, so we are joined by Dr. Kibet. He's going to give us his insight on your case from Kisumu.
Okay, sorry, I came in a bit late. So I had gone through the presentation, the PowerPoint presentation about the case, and of course, my question was whether these two represent or like one lesion, like the inguinal lymph nodes. Is it representative of the two ovarian tumors? And then if the morphology is reported to be suggestive of non-Hodgkin lymphoma, large cell lymphoma, then it's imperative, especially given the significant burden of ovarian tumors, to do IHC at least a CD20 to be able to, like a CD20, Ki67, CD10, the usual panel for non-Hodgkin lymphoma, to be able to confirm its name. I didn't get the size of the inguinal lymph nodes.
Kisumu guys, did you have the measurements for the inguinal swelling?
Yeah, it was approximately about 10 by 5 centimeters.
Okay, so if it is that large, then I think it's safe to mean to represent one and one and the same thing. So IHC would be indicated for this particular case.
So would you be comfortable with us going on with the treatment for lymphoma empirically as we're waiting for IHC? Because I think they've already given CHOP.
I do. No, for like lymphomas, especially large cell and buckets, I would really not hesitate.
Thank you so much for that input. I think we see a lot of difference if it's indeed lymphoma in the next 3 weeks as you're waiting for the next cycle to give your next chemo. And hopefully by then you'll have your IHC back. Thank you.
Okay.
Okay, the next case. So I'm going to present on a FJ. This is a 24-year-old female from Ward 6. So the patient was diagnosed with a rectal adenocarcinoma in December 2017. Then she was done colostomy fashioning in February 2018. She started on Folfox, that was in April. Then she got one cycle. She was due for second cycle on 31st of May when she was admitted due to complaints of abdominal distension, abdominal pain, general body malaise, and hiccups. So of note, colostomy was not to be active. So she was done abdominal X-ray, which showed multiple gas bubbles with the air fluid level. When she was done UECs, the kidney function potassium was found to be low at 2.74, with sodium of 106, urea 6.8, and creatinine of 61. Counts, the WBC was 8.8, HB of 15.1, and platelets of 430. So the patient was done a potassium replacement and also NMAX. So this is the X-ray that was done on 31st of May. As you can see, we have several gas bubbles and we have air fluid levels, which are features of intestinal obstruction. So the patient condition deteriorated and she became bedridden, and she was now being done potassium replacement, and she was taken in for surgery on 22nd of June for refashioning of the colostomy. So intra-op findings, they found that the abdomen was frozen with the tumor seedlings in the entire peritoneum. So they also noted that the patient had ascites. So they were unable to peel off the bowel anteriorly, and that is from the previous incision, and the entire abdomen wall too. So the stoma was assessed and it was found to be okay. So the patient as of last week was doing day 21 post-operative day. The colostomy is active and performance status has greatly improved. Now the patient is able to feed on her own with no complaints. So on examination, she was found to be in general condition, emaciated, not pale, not jaundice, no cyanosed. She was at COG 0. Per abdomen, she had a midline incision scar and the colostomy was active, and there were no organomegaly. Other systems, they were normal. So these are the labs of the patient since admission. Latest results, that is of 10th of July. WBC of 5.1 with HB of 11.7 and platelets of 381. UECs, the latest of 10th of July, it was a urea of 3.66, creatinine of 34, potassium of 5.18, and sodium of 126. So this is the abdominal CT that was done, and as you can see on the left, on the left, it shows the patient had partial mechanical obstruction, and this they attributed due to the fecal impaction. That's the reason why the patient was given NMAX, and there are no lung metastases. So the point of discussion today, given the history and the intraoperative findings of the patient, so what's next for FJ? And given the age and the performance status now of the patient, now which chemo alternatives do we have? Thank you.
Just a small, a question on how are the ovaries on the imaging?
They are reported to be normal. Yes.
Any questions? So, Dr. Kisilu, it would help if you just give a summary of your case so that you can see more questions can come up from the audience.
Okay, so in summary, so this patient is a 24-year-old female who was diagnosed with rectal adenocarcinoma in December, then done a colostomy in February 2018, got first cycle Folfox, that was in March, April. Then she was due for second cycle in May when she was admitted due to signs and features of intestinal obstruction. So they found that this could be due to mechanical causes. The patient given NMAX, which worked. Then kidney found to have hypokalemia, which was corrected. Then finally, when she was taken to theater, they found that the colostomy was working okay, but now the entire abdomen was frozen with seedlings everywhere due to carcinomatosis. So they just closed the abdomen, and now they advised now for palliative care for this patient. So the discussion was, since this patient had gotten first cycle of Folfox, then she was due to second, but now intra-op findings of extensive tumor, entire with seedlings everywhere in the entire peritoneum. So do we continue with the Folfox, or what other alternatives do we have, given that this patient is young and also the disease is quite extensive?
So, apart from the peritoneal seedings that they saw, do we have metastases to any solid organs?
There were no liver metastases, and there were also no lung metastases.
Kisilu, I want to just be clear on the age. Is it born 2004 or 24 years old? Because I was getting a bit lost.
Okay.
That's why I was asking about the ovaries. If he's a 13, 14-year-old.
No,
Okay.
sorry. It's born 204, so this 14 years.
14 years.
24.
Oh, okay.
Sorry. Very
It
confusing.
means a lot.
Born 2004?
She's 24
Just
years.
24 years old.
Yes,
Yeah.
she's 24.
Any concerns from the audience? Questions? So, Of course, it appears like we are all in agreement that this patient has rectal adenocarcinoma. The patient has only received one cycle of Folfox. From that, we cannot clearly tell whether the tumor is responsive or not to just that one cycle of Folfox. And from what we know is that an alternative to Folfox could be capecitabine and oxaliplatin, which is more convenient and equal in efficacy, if not superior to Folfox. So that would be a possible regimen to try and see how the patient responds to. What we've done in the past for those patients we wanted to treat aggressively is add irinotecan to the treatment. The problem with that is toxicities, but then if the patient makes it through, they respond very well. My suggestion would be for us to consider the option of capecitabine and oxaliplatin at the moment, with the intention of doing at least 8 cycles every 3 weeks, and then we see how he responds maybe after 2 cycles. The palliative team at the same time needs to come in and, like for every patient, to just make sure the patient is comfortable and all the other psychosocial concerns are addressed. What is the performance status?
Now it is at 0.
And that's a very stable patient. So besides what I've suggested to you, you can still consult with the other members of the team to give you a way forward. But it's important for us to just go on with the treatment. We cannot comment or maybe decide that it's treatment failure at this time.
Okay, thank you.
You could comment. This is probably one of those cases that might be worth thinking about genetic like history, family history and stuff. For the possibility of having the familial syndromes that are usually associated with early onset adenocarcinoma. Like 24 years is a young patient, and I think it's worth. In fact, in good setups, you'd probably would want to do staining, either IHC or molecular staining for the mismatch repair kind of proteins. Yeah, because and I think where was the biopsy reported? Yeah. Okay, because it's like usually in such an age group, you tend to get more signatory adenocarcinoma, which is usually quite aggressive.
Sorry, the biopsy was done in Capsabit, and now my question is like, do we do those genetic testing here? Do you have the capacity, or in our country, do you have the capacity to do so? And if so, like relatively, how much are the cost?
Okay, for the molecular testing is usually not done within the country, but most labs do. They send outside, either India, Pakistan, or South Africa. But some centers do immunohistochemical markers, which is like a surrogate for the repair proteins. And again, because of the numbers, it's not a routinely done test. And I'm not sure about the cost, but it's usually quite expensive and sometimes prohibitive. Yeah.
How was the biopsy done? It's quite unusual to find the tumor spreading into the peritoneum before it spreads into other organs. It should expect the tumor to go to parts. Did they like go through the wall, or what exactly happened? Because it's possible the tumor can be upstaged in that, depending on how the biopsy is done.
For the first biopsy, I don't have much details. Yeah, for the first biopsy. So the only report that I've given is during the second time when they went in, thinking that this colostomy is not active. They thought maybe substructed or something. So they went for a version of the colostomy. That's when they found these findings. So for the first, I don't have the details.
because something may have gone wrong at some point. Then,
Yeah. Of late, I see like transmittal co-biopsies. I don't know, like what's the role of them, both for gastric and bladder tumors, colon colon masses, especially. I guess interventional radiology is quite accessible and easy to get these days. So I'm seeing things that I never used to see in the past, like co-biopsies of colon mass and everything. But then nonetheless, in this XLab, is like something biopsy from these omental seedings. Done any idea?
No, they were not done. So they just so the patient has already histological diagnosis. So them they wanted now to refashion just the colostomy, but when they found this extensive tumor, they just closed. They didn't do anything.
the ideal way to go about it would be either to do a rectosigmoidoscopy to get the biopsy, and for the upper GI tumors, they can do an endoscopy. So that would really help contain the lesion regardless. Thank you. Any other concerns? From Kisumu, you've been very quiet.
A question. You can hear us?
Yes, we can hear you.
Yeah, just to add on to what you had said, so you've decided the patient will continue with Folfox, or now we do capecitabine and oxaliplatin?
So this is my thought. Folfox is not as convenient as capecitabine and oxaliplatin, and it has the same efficacy as capecitabine and oxaliplatin has the same efficacy as Folfox, if not superior. Added to the advantage of convenience, it should be your treatment of choice at this point as we keep consulting. And because of the good performance status, adding irinotecan on the treatment is a possibility as well. So we're going to get some more clarifications and agree with a few more people before we go on with that treatment.
Okay.
Any other question?
No, we don't have.
So I think we can go to our next case.
So we are waiting for Silvanus to put up his presentation. What is it? Okay.
Good morning. I'm Silvanus. I'm presenting a case from surgical oncology. Patient JJ, 37-year-old female from Kapsabet with a diagnosis of invasive ductal carcinoma. A 32-year-old female diagnosed with breast cancer in 2015 by a core biopsy which showed an invasive ductal carcinoma grade 2, having presented with a minor history of breast lump in pregnancy, which was 4 weeks. Termination of pregnancy was done and patient was started on adjuvant chemotherapy, SC, in October 2015. She did 3 cycles and was referred to do an MRM, that's a modified radical mastectomy, and she did in December 2015. She later continued with a 4th cycle of SC in January, and again she was started after 2 weeks with a docetaxel first cycle in January 2016. Patient lost follow-up after the first cycle of docetaxel till April of 2016 when she came back to continue the adjuvant chemotherapy, but was referred to radiotherapy then. In May, she developed a right chest wall mass. That is before she went for radiotherapy, a 6 by 4 centimeter. An excision was done and histology showed again an invasive ductal carcinoma, histology grade 3. She went for radiation, which she did 30 sessions and finished in October 2016 at Texas Cancer Center, where she will follow up after radiation. She now presents with a recurrent chest wall mass, which started in May 2018, and she went to Kapsabet District Hospital where an excision was done again, but no histology was done. Now the mass has recurred again. A month, it has been progressive over a month. Past medical surgical history, she has an history of previous admission, as history of surgery, which was done MRM in 2015, and has a positive familial history of breast cancer. General exam, she was in a fair general condition, not pelvic jaundice, EGOG1. Vitals were within normal. Local exam, there was an MRM surgical scar on the left chest wall, obvious mass over the sternum above the surgical scar, palpable 6 by 6, firm, fixed, non-tender, and a bulbable right axillary nodes which were matted. That's how the patients look like now. So this is the first MRM scar. This is the second excision scar, which was done here, the first one in 2016 and at Kapsabet. This is the first diagnosis, the first histology results. A breast core biopsy which showed an invasive ductal carcinoma grade 2. That's the mastectomy histology, which the comment, all the lymph nodes were affected by the tumor, but the margins were free of tumor. That's the excision biopsy before she went for radiotherapy. Our CT scan was done this last month, which showed a superficial lobulated heterogeneous soft tissue mass seen anterior to cervicsternum, measure 7 by 5, 7 by 7 by 6. Mass has a lytic bone destruction of a cervicsternum above suggestive of likely metastatic extension. A biopsy was recommended. Multiple suspicious left axillary nodes likely post-inflammatory. So we saw her at the surgical oncology outpatient clinic. She did a core biopsy. She sent for histology and ERPR. We did request for an abdominopelvic CT scan, which is yet to come. Our point of discussion: what will be the next management for this patient? And again, did this patient receive the standard care before? Comments?
Thank you so much, Silvana, for your presentation. Any comments from the audience, including Kisumu and other people who are joining us via the telemedicine platform?
Hello.
Yes. Yes, she got 4 cycles. That is SC, 4 cycles, and 1 cycle of docetaxel.
Someone from Kisumu had a question. You can go ahead.
Yeah, you can hear us?
Yes, we can.
Yeah, I just wanted to inquire on the first diagnosis done in 2015. And were there any imaging done for staging? And I've not seen any immunohistochemistries. Sorry, the receptors done at any given point.
So imaging was done, which was a chest X-ray and abdominal ultrasound, which showed negative for metastasis. Immunos was not done at that time.
Until now, has it been done now?
No, we took a biopsy on Friday. We're waiting, then we'll do immunos on the biopsy.
That's a good question. Any other questions or comments?
And then for now, with the report CT scan of the chest, can you just go? Yeah, with the mass and the lytic bone distractions of the Ziphis sternum. My opinion is I'm seeing probably now she already has some bone meds, and possibly starting her on zoledronic acid would be ideal in this case as well, as we plan on other management.
Thank you for the comment. Any other contributions? So, thinking about this patient. So first of all, she received 3 cycles of adriamycin and cyclophosphamide. That was back in 2015. And then they called that neoadjuvant. They did an operation, and then she got 1 more cycle of AC. And then they went to docetaxel. She only got 1 cycle and then got lost follow-up. So just for clarification purposes, when we say neoadjuvant, we don't mean half the treatment. The patient should keep the complete regimen that you intend to give before the operation. Some concerns come up because if you give the whole treatment, the primary lesion disappears. So it's very important that the patient is evaluated in the first place by, say, the surgeon. Should you be planning to use maybe modified radical mastectomy or something of the sort, so that they don't lose the primary markers that they had of where the lesion is contained. So that is the first thing that maybe was not so correct. Ideally, this patient should have maybe got 6 cycles of docetaxel or 6 cycles of AC, or maybe 4 of AC and 4 of docetaxel, which should be considered a complete regimen. So that is the first point that I have to make. Your adjuvant is not half the treatment. And then another interesting fact is that this patient got lost follow-up after one cycle of docetaxel. And on the same note, it appears like she could afford to go for radiotherapy. So what I'm wondering is whether she was not so well counseled about the importance of adhering to treatment, because if she could travel all the way to Texas, she definitely could afford to start care for the remaining sessions of chemotherapy. So patient education seems to have been amiss. It's a good thing that now you have a mass that you biopsy. Depending on the outcome, we'll draw a plan of treatment. For this patient in particular, I would suggest maybe going to taxane. Say you repeat the docetaxel because you don't have the maximum lifetime dose that they can get without getting toxicities. So you could repeat the taxane and then you add a platinum on it, like carboplatin, and that may give the patient a really good chance of survival. There is, of course, the lytic lesion, and as our colleagues from Kisumu have said, zoledronic acid may help, but sometimes for lesions that are very localized and you're concerned about them, you may give some radiation to control the treatment as part of the treatment for the lesion. I don't know if you have any other questions, Sylvanus, or concerns that you can address.
I have a question. Yeah, possibly now the way we are dealing with the metastatic disease, we still want to aggressively treat this patient in this case.
So for this patient, at this point, we need to first of all go ahead and do more staging investigations. What we have is only a chest CT scan. The patient has had CA breast from 2015 with suboptimal treatment. There is a significant chance that this is extensive metastatic disease, and that we can tell once we do the abdominal pelvic scan. Sometimes, if all the metastasis that you have is one single point that is very localized, you may try to go aggressively at that single point of metastasis and kind of take care of the primary tumor. But for this patient, we are yet to actually finalize on how aggressively we should be. If it ends up being only that sternal lesion that has been seen, that can easily be radiated, and then we aggressively go after the primary tumor that is there. But this, at the same time, is a likely metastatic disease, and our point of treatment is palliative and not curative.
Thank you.
Of course, IHP is very important.
Any other comments?
In 2015, what was the stage of the patient?
So initially in 2015, there were no metastases. So probably it was, I couldn't find the comment on the file.
And like Sylvanus has said, what was done in 2015 was a chest X-ray and an abdominal ultrasound, which is not ideal for staging, but at least they did not see any lesion. Clearly, the patient has survived since then without much treatment, so likely it was early stage disease. Any questions?
Was surgery contemplating to the exercise stomach?
No.
Okay, seem to have a way forward for this patient. Any other cases? Kisumu.
We don't have any cases left.
Okay, I wish to thank everyone who joined us for this Tumor Board this morning. The next session is going to be next Monday. Thank you so much for the cases that you presented. My colleague, Dr. Kilach, had a concern about the patient that we presented last year. Last Monday, the achondroplastic patient with CA breast that you're supposed to probably refer to Eldoret for further assessment and treatment. So where are you with that process of referral?
I'll consult with my other colleague because she's the one who presented that time I was not around, and then I will get back.
Okay, thank you so much. The Tumor Board is over for today.
Thank you.
Yeah.
Bore. Bore. Bore, are you there?
Yes.
Request you to remain behind just shortly.
Okay.
Yes, there's something I wanted to introduce. Someone I wanted to introduce to you.